So one question, sir. In the days of high specialization, whether the surgery done in a high volume center and a surgeon who is specially interested in foregut oncology practice, or the outcomes are different compared to a center where all malignancies are handled at a surgeon who is dealing with all broad surgical oncology practice.
At least for CA esophagus, very clear that care has to be centralized. Outcomes are definitely different in high volume centers, in high volume surgeons' hands. So there has to be it's preferred that these patients are referred to a centralized center where you not only get the good neoadjuvant protocol, you also end up in participating in studies. Like it helps the entire science of the problem.
And why we are not talking about, there is a discussion trans-abdominal versus transthoracic previous days. In the days of minimal access surgery, are we not applying laparoscopy first and if necessary, VATS, something like that, rather than surgeon dividing that somebody will be doing transhiatal minimal invasive versus somebody who is doing transthoracic video-assisted thoracoscopy?
No, the discussion was about what is the role of transhiatal, which is supposed to be a blind approach for doing a CAG junction. The standard of care these days across all units we have seen is a thoracoscopic approach, which can be either with a thoracoscope or with a robot. This I wanted to show that you can also do a trans-abdominal approach in a selected group of patients if you have good exposure and training in that, and you can achieve similar oncological outcomes. I think that, and like Dr. Rajneesh and Haribhakti sir made a point, you will come across a patient where even though you are a 99% thoracic, transthoracic approach surgeon, you will have to resort to a abdominal approach because of patient factors. And you should be prepared for that.
So I differ with you, sir. I am Dr. Nusrat from Baswa Tarkam. So transabdominal versus transhiatal, there are two properly randomized control trial conducted. So let us analyze one by one. So the results which were shown by you by Halcher et al. Okay, was only at 1 or 2 years, and what he has shown is the projected survival of 5 years, and the trial has also presented a 5-year survival at 5 years. Okay, and which was presented in 2007 by Omlu et al. So the trial has clearly shown there is no advantage between transhiatal and a transthoracic extent with extended lymph node dissection. Okay, and the trial has included only type 1 and type 2 adenocarcinoma of esophagus. Okay, and the trial has also clearly shown at 5 years the 5-year survival was 36% and 34% in transhiatal and transthoracic esophagus. If you further dissect the trial, so the trial has shown that in those patients who had more than 8 nodes positive, so there was no disease-free survival. The loco-regional disease survival was almost 0 in both the groups. And if the 1 to 8 nodes positive was analyzed, so there was clearly difference in favor of transthoracic esophagectomy, which was 65% versus 24% in favor of transthoracic esophagectomy in type 1 and in 1 to 8 nodes positivity, and coming to lesser than this thing, and type 1 esophagectomy as a whole, there was the 5 years overall survival was 51% versus 36% with a trend towards the transthoracic esophagectomy. So in those patients who has more than 8 nodes, though there was a necessity of giving neoadjuvant therapy. So coming to the other trial, which is 9902 by Japanese group, they have clearly shown that at 10 years, so there was no advantage, and in fact that transthoracic esophagectomy was detrimental in terms of survival. The survival was 37% in transthoracic versus 24%. The survival was 37% in transhiatal group versus 24% in transthoracic. So I've clearly showed this transthoracic should not be done in type 1 and type 2 adenocarcinoma of esophagus. And there are two
Dr. Nusrat.
nationwide studies
Dr.
published
Nusrat.
from.
Dr. Nusrat, because lack of time, what is exactly point you want to say? Because we'll close it once.
Transhiatal is a good approach for a adenocarcinoma of esophagus. Esophagus.
To see that in the perspective of the pre-neoadjuvant era trial.
Yeah.
So we
Post-neoadjuvant-
can take it as it's safe, but extrapolating to its oncological survival superiority may not be relevant.
Yeah, sir.
I
The
think,
post-hoc-
because there's
post-hoc
a-
analysis of
Dr.
the
Nusrat-
cross trial and